And our next speaker will be Associate Professor Dr. Chai Chi Si, and his topic would be optimizing asthma and COPD in a resource-limited setting. Dr. Chai is an Associate Professor of UNIMAS and as well as uh, the head of department of our Department of Medicine. And uh, he is a graduate of UNIMAS, and he's also a consultant respiratory and internal medicine physician at the UNIMAS Medical School, Kota Samarahan. He obtained his Master of Medicine from UKM, and he's also a member of FCCP from the United States. And he holds a fellowship of respiratory medicine in Malaysia. His expertise include obstructive airway disease, sleep breathing disorder, COVID-19, and driver oncogene lung cancer. He has extensive publications, totaling 17 research grants amounting more than 1 million, and with a total of 41 publication in peer-reviewed journals. So, Associate Professor Dr. Chai is also a member of American College of Chest Physicians, European Respiratory Society, Asia Pacific Society of Respirology, and Malaysian Thoracic Society, as well as editorial board member of Biomedical Central and PROS One. He has received numerous awards of teaching excellence and service excellence from UNIMAS. Without further ado, I'd like to invite Dr. Chai.
All right. Thank you, Dr. Yeo, for your kind introduction. So everyone can see my slide, right? Can see, yeah?
Yes.
Okay, so today I try to make it short and interesting. So my topic is optimizing asthma and COPD in a resource-limited setting. So the keyword is resource-limited setting, right? Okay, so first and foremost, I would like to say thank you to all the healthcare workers, mainly you all, most of the participants from a district setting. We understand that it's not easy to serve in a district with a lot of limitation, a lot of sacrifice. So that's why we organize this sharing session with you, to acknowledge your contribution and, to say thank you to you all. All right, okay. So first, when we talk about the principle in medicine, okay. So when we talk about how you approach a disease, you always remember we have 3 steps to approach a disease. First, you have to make an appropriate diagnosis, right? Correct diagnosis, that is the most important. First step, you make sure you get a correct diagnosis. Second step, you initiate a appropriate treatment. Treatment must be appropriate. And subsequently, you follow up the patient. It's 3 steps, it's very simple, but in fact, it's not so simple, right? Okay. So if you talk about asthma, you talk about COPD, we refer to 2 guidelines, right? 2 guidelines. The left side is a blue color. You see the blue color is called GINA guideline. GINA guideline is for asthma. GINA guideline updated every year. So the 2013 already out. The right side, the yellow color is for GO. GO is for COPD, updated every year. 2023 just released also, right? So this is ideal. And in the modern days, we practice evidence-based medicine. So we follow guideline. Unfortunately, this guideline, is evidence-based. That means they use a very good drugs, very effective, very expensive, and may not available in certain country, right? So this is a worldwide guideline. Right? Ideally, you should follow this. Ideal. All right. However, Malaysia is a very interesting country. And Malaysia, is a very special country. You see, we have, Malaysia big land. We extend from Perlis to Sabah. We have different type of people, different culture, and also don't forget, we also have city and district, all right? City and district, this is another challenge, right? Okay, so basically we have a big city like KL. Basically in this area, you may able to practice like what Gina and Go say. But don't forget, we also have a place that cannot access by road, but using board, places with place, without electricity and water supply. So in this condition, it's difficult for you to practice according to the guideline, right? So then this come to our topic, what should we do when the resource is limited? Okay, so this is my personal experience. Do some sharing first, right? So I start my houseman in Cebu Hospital. It's a tertiary hospital, mainly general. I mean, for medical, it's mainly general. Subsequently, I had my district posting, I work as in Sri Aman Hospital, secondary hospital. I joined UNIMAS subsequently and have a brief stint in South General Hospital. It's a tertiary hospital with more subspecialty service compared to Cebu, And subsequently, I have my specialist and subspecialty training in UMMC. So this is the only quaternary center in the country and the second biggest hospital in the country. So, quaternary means admit direct to subspecialty, direct to subspecialty. And now I'm back to UNIMAS, the wonderful campus with a leg. And we are in the process of building our tertiary hospital with mainly general, with subspecialty service. All right. So the experience of having gone through all these different hospitals, tell me one thing, we have limitation. All right. In different, you cannot expect, you cannot expect every hospital to perform, to follow a GINA or GO guideline. You cannot expect, you're able to prescribe the best medication in each hospital because everywhere there is a limitation. So always understand we have our limitation. We have to work within our limitation, right? Okay. So this comes to our topic today, right? So understand we have limitation. We have to work within limitation, right? So first thing, okay, before we proceed further, today's topic is asthma, COPD. We have to know asthma, COPD, airway disease. Both airway disease. You can see airway, the red color is airway disease, right? Okay. So the big airway is usually due to mass. Okay. Asthma and COPD is a smaller airway disease, the lateral one, right? Okay. So under airway disease, we have mental group, bronchial asthma, 20 to 40% population affected, COPD, 10%. And do not forget, there's a group, you have asthma and COPD overlap. Your cause ACOS, right? So this asthma, if let's say you're not sure, it's a borderline sitting on the fence one. We always approach as a asthma, right? Okay. So basically, you know this. All right. Next thing, the challenge. Now we got in deeper to our topic, the challenge. Okay, asthma, COPD patient, they always tell you cough, shortness of breath, and wheeze. You cannot differentiate. If we have a lung function, both will show an obstructive pattern. So this is a challenge. And if you ask a patient, all the patient will tell you I have asthma. And because the term COPD, most of people don't know, right? So we go back. So it's important for us to go back to the basic first. Okay, we go back to definition. You have to understand the definition, to know how to manage, diagnose, manage, and follow up both disease well. Okay, so we go back to GINA guideline. Based on GINA guideline, asthma is a heterogeneous disease. That means one person do not same with another. And asthma is characterized by chronic airway inflammation. This is a keyword. Asthma, always remember, is a chronic airway inflammation with reversible type of respiratory symptom and expiratory airflow obstruction. That means, keyword, chronic inflammation leading to a reversible type of variable type of respiratory symptom and airway obstruction. Okay. On the other hand, you see the yellow one, COPD is again heterogeneous because they can present differently. Okay, it's a heterogeneous disease, due to abnormality in the airway, the small airway, as well as the ASAC alveolar. Okay, airway and alveolar. Okay, and causing persistent and progressive respiratory symptom and obstruction. So you can see both are very different in terms of one is chronic airway inflammation, one is the airway and alveolar abnormal, right? Both are different things, okay? Another thing is asthma is reversible and this COPD is persistent progressive, right? So actually, in fact, both are very different things. You have to differentiate. Okay, if you see back an airway of a patient with asthma and COPD, the left side is asthma, right side is COPD. Left side, you see the airway is almost the same, but it's swollen. Inflammation causes the airway to swollen, airway narrow. Okay, during inflammation, but when inflammation resolve, airway go back to normal. That's why it's reversible. COPD, you can see the airway is narrow and the alveolar damaged. So it's persistent because already damaged. All right, you cannot reverse. So basically, asthma is a physiology disease. COPD is an anatomy disease, anatomy abnormal disease. All right, so this diagram even show the underlying cause better. You need to understand this first before we proceed further. Middle is a normal airway. Left side is the asthma airway. Asthma airway, you can see from outside is almost the same. Only the internal diameter is smaller because of airway inflammation. If you suppress the airway inflammation, the airway, the whole lung return to normal like middle. All right. On the other hand, right side, you can see COPD lung. COPD lung, airway fibrosis, smaller. You can see shrink already. And you see the alveolar dilated, okay, destructive. So in this condition, COPD, you know, is like, you know, is a complication of chronic inflammation. It's a complication. So basically, it's already destroyed. They cannot be reversed. They cannot be reversed. All right. So you can see different thing. All right. So it's totally different disease. All right. So these also come to, you know, not only in the different in terms of pathophysio, they also in terms of presentation different. So you need to know this presentation so that you can get a good history. Like asthma, they tend to be young. COPD, they tend to be older because COPD is due to, you know, destruction of the airway and alveolar. This is due to exposure to smoke. Okay, cigarette smoking, right? So COPD got cigarette smoking, asthma is more to having underlying allergy and so on, you know, and the disease is one is progressive, one is reversible. All right, okay. And spiral, if we're able to do one, you can normalize because it's a physiology disease, and COPD permanent destruction, so you cannot normalize. All right. Okay, more important, all right, why we need to differentiate both? Okay, because ultimately, if you diagnose a disease, you need to treat, all right? Because the treatment is totally different. Okay, the important is, you know, you get the right diagnosis, you can initiate right treatment. You get a wrong diagnosis, you initiate wrong treatment. When wrong treatment, the disease will never get control. All right. So the left side is based on GINA guideline how you treat asthma. Basically, we identify this patient suitable for which step, right? Then after that, we'll decide what step to use, and we use a horizontal approach. This step 3, not control, go step 4, like that, you know. If step 4 not good control, downgrade to step 3. It's a horizontal approach, what we call. For COPD, is different. COPD, what we need to do, first, we have to group the patient based on risk and symptom. You have to choose A, B, C, D, based on 0, 2, 0, 0, 2, and before. You have to decide patient is A or B or C or D. Then you start the treatment. After you start the treatment, you use a vertical approach. It's different. Vertical approach, you divide them into, is this exacerbation dominant or symptom dominant? Then you treat differently. So one is horizontal approach, one is vertical approach. There's a reason you have to diagnose properly. Another thing is drugs. Okay, like just now I mentioned, asthma is a chronic inflammation. The best drug to suppress inflammation is steroid. You see, it's a steroid. So in asthma, steroid is the most important treatment. Okay, so we go back to COPD. COPD is destruction of airway plus alveolar. All right, the inflammation probably resolved, so already permanent damage. So in this condition, you suppress the inflammation using steroid, no use. You have to dilate the airway. The already narrow airway, you have to dilate. In this condition, bronchodilator is more important. So you really make a big difference. One is using steroid dominant, one is bronchodilator dominant in your management. That's why you need to know which is this patient asthma, is this patient a COPD. Okay, now we go to our topic. Go to our topic now. Okay, so how to optimize asthma and COPD in a district setting. like I mentioned just on the 3-step. First, you really need to make sure you get a correct diagnosis first. You know, you don't get a correct diagnosis, you treat wrongly, never optimize the control. All right. So the important thing is how to differentiate COPD from asthma. All right. You always, as we know, we always take history, exam, and investigation. So I put the color for you. The color mean what? The risk of error, risk of unable to do. History, you may encounter some difficulty in district. Examination, I don't think so. I don't think there is a difficulty. All right. However, for investigation, right? Investigation, you always encounter difficulty in district setting and primary care. Even primary care, investigation always an issue. All right. Now I tell you why. Left side is a GINA, how you diagnose asthma. Right side, go how you diagnose a COPD. You can see, if you want to diagnose asthma, first you have to get a typical history, a good history. Number one, history, respiratory symptom variable, you know, diurnal variation, worse at night, aggravated by certain things, cold and dust. So you get this type of history. And in order to confirm, you have to demonstrate a variable expiratory airflow limitation. In this condition, first, most commonly, we need a spiral with reversible test, spiral with broncho provocation test, spiral plus a exercise stress test, because basically district you don't have spiral. So basically you cannot confirm. Based on GINA, you cannot confirm, right? Or another one, the one possible you can use is a peak flow, diurnal more than 10%. That's why in my student, I always tell them, next time you go district, you don't have spiral, by all means get a peak flow, get a peak flow. You may be able to help, maybe, but not always. All right. Okay, for COPD, you can see, you know, COPD is a respiratory symptom, progressive, worsening, persistent. Plus, there must be a risk factor. You see, risk factors, smoking. Again, even have all this, you have to get the confirmation by performing a spirometry. Again, the keyword, spirometry. All right, spirometry, you need a reversible test, which is negative reversible test, and fixed airway obstruction. So basically, conclusion is, if you want to diagnose asthma, COPD accurately based on guideline, it's almost impossible in this stream because you do not have a spiral. Right? So what can we do? What can you do? Now the question go back, you know, in district, what can you do? Okay, this is what can you do. Okay. First, I would say get the history first. Get the typical history like I mentioned just now. Get a history, very focused history, get a good history. Then another one, subsequently go back to very original. You mentioned, if you see back, GINA Go do not ever mention examination can confirm diagnosis. No, they only tell you investigation. Okay, but in district, you have no choice. Do a proper examination, still got trachea, still got barrel chest, loss of cardiac liver downers or not. Do an X-ray, hyperinfected chest when patient is stable. That would give you a clue, this is a COPD. Give you a clue, it's not confirmed. And as I mentioned, peak flow is cheap, 100 ringgit one. May help you, especially if a patient show a diurnal daily variation, daily, okay, the peak flow tell you possible asthma, possible this is asthma. If no diurnal, difficult already. You cannot say it's asthma, you cannot say it's COPD. Very tough, right? So this is a challenge, right? Okay, get a good history, like I mentioned to you. Left side is a history for asthma, right side is a history of COPD. You really need to get a good history in district because this is the best you can do. Okay, so first, get the good history, basically, you know, to get your diagnosis, most likely diagnosis, do a good examination, and probably there might be with the help of X-ray plus peak flow you can do. All right, second, this is even more difficult. Now you get a diagnosis, you want to treat. Okay, so now the challenge is in district, how to choose an appropriate treatment for asthma COPD. Okay, so we got pharmaco and non-pharmaco. Why I put pharmaco right is really a challenge. Basically, it's very tough to treat COPD in the district setting. Right, let me show you why. Okay, so this is the asthma treatment. 2013, 23, still the same. We divide. Basically, nowadays we treat asthma based on we identify the symptom plus you may need a spirometry again to start the treatment. Okay, pathway 1 is up one, pathway 2 is called as alternative pathway, second pathway. So basically, pathway 1, you need a drug with a formoterol containing, which is a Simicort. which is a respiratory item. This is a respiratory item, which means most unlikely, extremely unlikely you can use in this treatment. Okay, so you have no choice. Then you in this treatment, you may need to consider using, I think you most likely need to use the alternative, alternative option, the second pathway. Second pathway is alternative. So even you see a second pathway, step 1, step 2, step 3, 4, and 5. Step 5 is definitely unable to do in this treat because you minimum you need a LAMA. LAMA is something like Spiriva, and worse, you may need anti-IgE omalizumab, IL-5 benzalazumab, restizumab, cost 1,000. So basically, step 5 is out. Now the challenge is, can district use a 1 to 4? Possible. Step 3, step 4 is a drug called serotype. You can use serotype. But again, this is a specialist item, not MO item, it's specialist item. And 1 and 2, probably 1 and 2 definitely you can do. So I think most of the people can, most of the district, they can use a drug suitable for 1 and 2, 3 and 4. Very difficult. Unless you have family physician or internal medicine, general physician, they may be able to sign serotype. Okay, so knowing that is tough. Basically, you want to do ideal based on GINA, you only can do 1 and 2, right? So what can we do? Before what can we do? In a resource limited, you have to know the principle. Right? Principle in asthma is like this. Inhalation is better than oral. Okay, first principle. Second principle is ICS is better than bronchodilator. Remember that. Third is if you have long-acting bronchodilator, is better than short-acting. So based on this principle, so we can make a conclusion. If I have choice, I would choose the inhalation drugs. I would choose the drug that contain ICS. And if I need a bronchodilator, I would choose a long-acting. So this is your principle. Okay, so this is the strength of ICS, and beside the picture is the bronchodilator, SABA, left side Ventolin, right side Symbicort, serotype. So we don't talk about Symbicort because it's a respiratory item. You don't have in the district definitely. So the challenge is, ICS you have, whether what is the role of SABA and serotype if you have. So first question you always ask you in district, do I have a LABA ICS like serotype? If you get, no issue. Okay. If you do not have LABA ICS, if you have LABA ICS, basically you can go up to step 4 in alternative pathways. Okay. If you do not have, what can I do? I only can do until 2. You do not have serotype, you only can do until 2. So in this condition, what you want to do? You see, step 3 is low dose ICS, LABA. Step 4 is medium ICS, LABA. So what can you do? You have no choice. You do not have LABA. So what you do? You increase the ICS, right? If step 3 need low ICS plus LABA, you have no choice. Then probably you have to give high ICS plus a SABA. A medium. Okay, step 4, you need a medium plus a LABA, but because you do not have LABA, you have to give a high ICS plus a SABA. Okay, so you have to modify, no choice. And if still not control what to do, you do not have LABA. So what you will need to do? You always, then you need to add on other bronchodilator, particularly SAMA, short-acting, like your ipratropium bromide, because you do not have LAMA. District definitely, if you do not have LABA ICS, definitely you do not have LAMA. So you only can add on something like ipratropium bromide. If still not control, what can you do? The last choice, you give oral treatment like aminophylline. It's not advisable if you based on guideline, no, but that is in a rich country. So you have no choice. So you may consider, but steroid, no. Definitely not, because it is very detrimental. Maintenance steroid in asthma, no. You shouldn't, because a lot of side effects, right? And do by all means, always make sure you optimize, because you cannot get the best drug. When you cannot give the best drug, you really need to optimize other factors other than drug, like quit smoking, prevent dust, prevent URTI. All these things you need to optimize. Ensure adherence, technique correct. These things you need to optimize. The whole reason is you don't have the best drug. And by all means, if patient willing to get referral or you're not confident, refer. Right? So COPD, ABCD. First thing you need to define patient into ABCD. Okay, E is a new one. 2013 is E. I don't want to talk about E because E is impossible to start in district. E definitely you need a LAMA plus a LABA together, combination. Something like a Spiotto, something like Altipro. It's a respiratory item you do not have in district. So I put the red color one. You know what you have in this week? Lama, very difficult to get. You know, Spiriva, unlikely. I also think unlikely. Laba per se is almost unlikely. The most you get is, you know, either you get a combination of Sabah and Sama or ICS Laba, which is just how I mentioned to you, serotype. So it's difficult to treat based on gene guideline. It's almost impossible. All right, so if you want to subsequent treatment, the exacerbation dyspnea, you can see the drug even more complicated. You need a LABA plus ICS, you know, all these combination drug, roflumilast, azithromycin, or respi drug, very expensive drug. You cannot get. So in this condition, the more still you want to escalate, you still can escalate to LABA ICS. All right. LABA ICS is not a very good drug in COPD, but you have no choice. Okay? Because that is a possible available in this treatment. Okay, go back to principle COPD. You need to understand this also. In COPD, inhalation better than oral, bronchodilator better than ICS, right? In bronchodilator, antimuscarinic is better than beta-2 agonist. Okay, combination is better than single. Long-acting is better than short-acting. So based on this, the principle is like this. I would choose an inhalation drug. I would choose a bronchodilator over ICS. You know, if I want to choose a bronchodilator, I will prioritize an antimuscarinic. Okay, I will try to give a combination drugs. And if got long-acting, I will try to choose the long-acting. This is how you choose, how you play around with the drugs. Left side is a drug for COPD, right side. This is how you do in this string. Is patient suitable for SAMA plus SABA only? I can tell you unlikely. That is group A. Most patient unlikely they can. So most when you cannot, what can you do? You ask yourself, do I have LAMA in district? LAMA is a specialist item, specialist item. Very even that also don't have. I don't think have. All right. If still don't have, then you say, can I give LABA ICS to patient because I do not have LAMA? LAMA is better than LABA. Can I give a LABA ICS to patient serotype? If I still don't have serotype, or you know, then you have no choice. You have used the SABA plus SAMA combination therapy plus oral medication again, something like aminophylline. Maintenance steroid, no, in COPD because no law. Okay, aminophylline, be careful, cardiac arrhythmia, liver issue, and also kidney, and also gastritis. That's why to be honest, in a tertiary, in a very good hospital, they don't give. So you have no choice, limitation. All right. Again, go back to just I mentioned to you, when you do not have a best drug, always optimize other factor, and always do keep in mind referral is another option. All right. Okay. So just now I keep on talking about, you know, LABA ICS in COPD, LABA ICS in COPD, not a very good drug to choose, but you have no choice. Okay, if you have no choice, you have to use. But be careful. When you want to use, you make sure do not have this. Okay, in this treatment. If you have LABA ICS, you want to use, make sure patients subsequently do not have repeated pneumonia. If they have repeated pneumonia, the ICS has to take off. The reason we choose LABA ICS is because we want the LABA. We want the long-acting bronchodilator. Unfortunately, if there is pneumonia, you cannot give. History of TB or subsequent get TB after that, you also cannot give. Right? So be careful of this. All right. You try to give a best treatment, but there are something you need to look after. All right. Okay, next. You talk about treatment, how you choose. I tell you how to choose. You can read later. Vaccination in asthma and COPD. We need vaccine other than COVID vaccine. You have to vaccine both population with influenza. And COPD guidelines say you have to add on a pneumococcal. Unfortunately, vaccine, we do not have alternative. You cannot escalate, de-escalate, you know, modify. Unfortunately, if have, give them. If don't have, no choice of what to do. All right. Either you refer lah. Okay. All right. So last one, follow up. How to approach patient with poor control bronchial asthma or COPD? Simple. This is what Gina asked you to do. So you make sure patient know how to use inhaler, adherence, confirm the diagnosis. This is what you can do. Actually, all these things you can do, except when you accept the consider treatment step out, that is an issue you may encounter. But the first three you can do. And last one, always remember, if cannot manage, by all means, refer. Right? COPD is the same. The review, under the section of review, you can do almost the same like asthma. You know, you get confirmed diagnosis, you check adherence, you remove aggravating factor. I think that is the best you can do. By all means, still no good, you have to refer. All right. So I think almost done. My session done. Right. Okay. So this is a bring home message. The last two slides bring home message very important. When in the district you have a lot of limitation. You have to modify. You really have to modify. You cannot follow guideline because you don't have the resource. Modify the treatment based on what I say just now. Okay, and also always keep in mind, if you cannot provide the best care, if there is option of referral, there is a chance, there is a space of referral, by all means refer patient for a better care. Better care, right? And this is the last slide, bring home message. The left side, I download for internet. I think you always need to try your best. We always try our best, but at the same time, you can only do what you can. Understand? In district, you try your best, but you can only do with what available in your hand. Okay, right? Don't beat yourself up about it. So basically, if you cannot do what to do, refer. Okay. So what the right side is what I want to tell you all. The summary. In a resource limited setting, we may not be able to give the best treatment. Most unlikely we can give the best treatment, but always, but you still can always try your best to give the best treatment that is available, all right, by modified just now or by making proper referral. All right. Okay, so then that's all for my presentation today, and thank you for your time. So any question?
Okay, thank you for Dr. Chai's excellent talk. Due to time constraint, I think we'll leave the question and answer session to be conducted via using the chat box. And I think I can sense the hypoglycemia among the audience. So I think it's time for us to go for lunch, and then we'll come back and gather here again at 2 p.m. Is that okay?
And I will answer the thing in the chat box. Can
Yeah, yeah.
Direct. Okay, thank you
Yes.
everyone. Thank you.
Okay. Right. See you later.
Thanks.